Now I'd like to invite Dr. Mark Alford to tell us about the magic dust, the urinary bladder matrix.
Good afternoon, everyone. I want to thank Jeremiah and Rich for asking me to talk. It's kind of a silly title, but I think I'm going to give credit to Dr. Rachel Sobel or maybe Louise Mon, who I showed some of these pictures to, and they said, "Oh my gosh, that's like magic dust." And so that's how that title came about. So what I'm really going to talk about today is a product that's really a xenograft, and it's kind of think of it as a skin substitute for reconstruction. And so I have no financial interest, and since I'm going to be talking about one product so much, I wanted to make it clear, I'm not a shareholder, I'm not a paid speaker, I'm not a consultant, I've never had any of that product given to me, so I just use it. So just wanted to make that completely clear. So the question we're really going to ask is, what is urinary bladder matrix? Is it a good skin substitute? Can we use it around the eyelids? And what is this material, and how does it promote healing? So just in review, a little bit about the skin. Here's the epidermis, the dermis, and we're going to be talking about the extracellular matrix. That's the thought of using this material. This is the extracellular matrix down in here. The pink stuff is collagen, and there's some probably macrophages and fibroblasts down here, and this is a more magnified appearance of the extracellular matrix, and you notice how it's kind of this loose mesh-like, almost like gauze. One of the things about scar tissue is this kind of matrix, this loose appearance starts to line up in parallel bundles, and it gives us that weird look. So that's kind of the difference in scar tissue. So the way the extracellular matrix, the dermal extracellular matrix, is made up, it's really proteins and carbohydrates. The main protein is collagen, and that gives us strength and structure, and that really is what helps heal defects. The collagen is woven together with proteoglycans. It's attached to the cell at integrin, which is it's in the cell wall. With fibronectin makes those attachments. Integrin probably has a lot to do with monitoring the extracellular environment. And of course, glycosaminoglycans support the environment, and that would be like hyaluronic acid. Kind of think of it as a lubricant. And then of course, there's a lot of fibroblasts in there too. So this material that I'm talking about is called Maitre Stem, and it's a xenograft, so that means it's not made from humans, it's made from animal. It's made by a company called Acell, and it's in Columbia, Maryland. It's an American company. It's made in the U.S. So it's a urinary bladder matrix, and so what that really is, it's extracellular tissue matrix derived from porcine bladder lamina propria. Yes, it's pig bladder. They grind up pig bladder to make this material. And how it works, or how it's thought to work, it provides naturally occurring growth factors, multiple collagen types, laminin, fibronectin, proteoglycans, and elastin. And this is a slide from the company, and it shows a lot of this is actually the material, magnification of the material, and then it has some of the things that are actually that are present in the pig bladder. All these forms of collagen, these proteoglycans, all these growth factors, there's VEGF, glycoproteins, laminin, elastin, fibronectin, what we talked about, and even some anti-infective kind of proteins. And there's a lot of literature on this anti-infective proteins that are in pigs. So how does it work theoretically? Acts as a bioscaffold to promote epithelial cell growth. The goal is it's going to make that scaffold so the epithelium heals over the top. There are studies that show that there is decreased fibrosis in these tissues. It maintains and supports a healing environment, supposedly facilitating the remodeling of site-appropriate functional tissue. The way to think of that is it probably prevents those parallel bundles of scar tissue. Maybe it accelerates the natural healing process. And let me make this totally clear. This is not something I figured out or, just have started. I'm the first person to use it. It's extensively used in burn surgery and in general surgery. So, for instance, this is from the company, and it shows like the tip of a finger that's been traumatically removed, and they use the Acell product on it, and you know, the tip grows back even with the fingerprint. Crazy. And then here's another, this is the kind of thing that's used in general surgery, these large, non-healing abdominal wounds where they lay these sheets of the ACell material over the top, and then we have this kind of healing by second intent, potentially. So just in review, an allograft is derived from human tissue, and that would be alloderm, D-cell, transcyte, some things you've probably heard of. Some of you might be using that. Xenografts derived from animals. Integra is probably something, a lot of people ask me about Integra. Is it the same kind of thing? So Integra is made from cow, shark, and then has that silicone layer on it. Oasis is pretty popular in general surgery and in burn, and that's from the pig jejunum. And then there's another Maitre Stem bovine ligament. So you can tell there's a lot of stuff. There's at least 25 to 50 products out there that are similar. So we're going to talk about the Maitre Stem from ACell. It comes in these little powder vials, and it comes in sheets. This is what the product looks like now. It comes in a little vial of 100 micrograms. So I thought I'd just show you some pictures and kind of my initial exposure and experience with this material, and just kind of show you a slideshow. So here's my typical kind of, just like Mark was showing, the Mohs patient that comes in with this defect, and just look how terrible the skin is on my patients, you know. So I'm going to rotate a flap from here into this hole with all this bad skin, you know. So the typical thing is we're going to do a rotational flap of some sort to fix that. So would there be any other way maybe to fix that? And so that's the thought of this ACell material. The way this is a little bit of my initial exposure to it, so I kind of followed how these patients were doing. But originally, I had a patient with Epidermolysis Bullosa that just wouldn't heal with conventional wound care over a couple of years. And I'll show you what happened with her, and then I started using it in some other patients. So just quickly, Epidermolysis Bullosa is a skin disease where they have a defect in laminin. There's various problems with it, but in this patient, she had an autosomal recessive defect in laminin. And I was looking for some kind of product that might replace laminin. And so that's how I came upon ACell. And it's a terrible disease. Their skin sloughs off in blisters. They usually die in their 20s. This patient was one of the older patients around. There's really no cure for it, and of course, two years with no healing. So she was referred to me for ectropion. So you think, oh yeah, just ectropion. Well, this was her ectropion. So this lesion is not healed, and you can, you know, she's got corneal scarring. I mean, these patients almost are all blind from this kind of thing. So I'll show you the technique of how to use ACell, but in general, here's the ACell, here's pre-use, and then it starts to heal, and then it heals a little more, and that's kind of the end result, which was pretty dramatic. And, you know, even her ectropion improved a bit. So I thought, well, if it works on that, I wonder how it works on Mohs defects or defects around the eye. And so here's this kind of difficult lesion in a relatively young patient, and you notice it's really superficial. It's not very deep, but it's big, and it's right there in the brow. You know, how are you going to fix that to make that look good? So, well, the way I started doing, and this is the way a lot of the burn surgeons do it, they sprinkle on the powder and then lay on a sheet. And this is so the powder is just the ground up pig bladder, let's just think of it that way, and the sheet is kind of the ground up pig bladder processed into a little sheet, and it comes in different thicknesses. And then I put some ointment on it, and I put this occlusive bandage, and this is what she looked like in 4 weeks, and this is what she looks like in 6 weeks, and you can tell that it's just quite smooth and nice and kind of magic dust, you know. So there she is. And this is, you can tell this one has nicer skin than most, and she's relatively young compared to most of my patients. So I'll just show you some more. Here's a guy with a lower lid defect. You can tell he's kind of frail looking, and this is a couple of weeks out with the ACell sheet over the top. You can see I've sewn it in there, and then here he is at 6 weeks. Now, I did do a lateral tarsal strip on him to tighten the lid, but relatively nice healing. Now, here's where it's really effective, where I use it. Little medial canthal defects like this. Again, look at his terrible dermatitis, just awful skin. You know, just nasal skin, all this inflammation. So in here now I've put in some of the powder and I've sewn on the sheet, and the sheet gets a little moist. And then this is his 6-week result. Nothing else. That's it. Now, here's a 36-year-old woman, and in Texas, I mean, everybody has sun damage, so it's not uncommon to have 30-year-olds with skin cancer. So she comes in from the Mohs surgeon, and you notice she has all this, acne, rosacea, terrible skin, thick pores. She comes in from the Mohs surgeon with 2 basal cell defects, and they're packed with Surgicel, so they're kind of deep. And I did the same thing with her, the sheets and the powder, and we patched her for 2 weeks. This is what it looks like when the patch comes off. That's the sheet. It's kind of crusty and gross. And then here's 4 weeks, 6 weeks, nothing else done. Okay, no lateral tarsal strip, just that. Okay, so here's a guy tried with a little ectropion, just his lid was relatively tight, made a little incision, and just look at his terrible skin. Where are you going to get a skin graft? Put the A-cell sheet in there, and then that's him at 6 weeks. Okay, it's not great for the lid like that. Here's a patient with ichthyosis, and if you guys have these patients, they're very, very difficult to help, and they're in a lot of pain. So I thought he needed a big skin graft down here, and so I took a big skin graft, preauricular graft, and so I used the A-cell to heal the graft site, the donor site. So this is the A-cell. Now I'm starting to use putty. Basically, I take the A-cell, I add a little saline and a little ointment just to make a paste or a putty, and I just filled that in my preauricular graft and then put a bolster on it for 2 weeks, and I'll show the same technique. This is the size of skin graft that it took to repair the lower lid, and this is the donor site in 6 weeks. I didn't close it at all, I just used the A-cell. The patient needed more skin graft. So I went back to the exact same site, took exactly the same amount of skin again, and in 6 weeks it healed like that with just A-cell, no closure. And if you just don't, this is the same, it's the same eye. Okay, so here's kind of the way the powder comes in these little vials. I put it in here, I moisten it and put a little bit of ointment just to make it a workable putty. That's the sheet. I usually do a betadine prep, sterile application of the paste, sew on the sheet, bolster it for 2 weeks, and then ointment until healed. A couple of big defects. Look at this thing, just a big nasal defect. There's the putty or the paste. There's the sheet sewn in place with a little chromic, bolster for 2 weeks. There's 4 weeks, and there's 6 weeks. And with his general office procedure, and then here's another one. So this is just kind of the standard technique now. Mohs defect, the paste, the sheet sewn in with a few chromic sutures. In the office, usually they come right from the Mohs surgeon. I don't even add any more local, they're still numb. Nice little bolster with a Maricel sponge. Here he is at 2 weeks when I take the bolster off. The patients think this looks horrible. They all come, a lot of times they'll say, I have an infection. What is all this? This is just the healing process. Here he is at 5 weeks out. So tried to give you a real close-up here of what that looks like. Lid margin looks good, so pretty easy. It takes about 10 minutes to do this. So the results of using this is basically, it shows evidence of healing with minimal or less scarring than maybe by second intent. No rejection, allergy, or infection. Dressings and ointments are usually discontinued by 4 weeks. Quick and easy to apply. All patients complain of wearing a bolster or the dressing for 4 weeks. Here's the cost. Everybody's got to be thinking about this. The 100 milligram vial of the powder is $360. The sheet is $86. If you do it in your office, you get paid $150, okay? That's the CPT code. It's not bundled with other eyelid codes, so it could be used with other procedures. If you do it in the hospital gets $430. So it's not very expensive material. So is it magic dust? Well, probably not, but I think it's an effective alternative to granulation, skin grafts, and flaps in selected patients. And I really like medial canthal defects, preauricular skin graft donor sites. You can also use it behind the ear, it works great. And I think it works nicely along the rim and the brow. So again, it's fast and easy to use, relatively inexpensive. You can keep it in the office on the shelf. It doesn't need refrigeration or anything fancy. You can do it in the office, local procedure, and I think it's particularly useful in young patients who just don't have a lot of skin to mobilize, in poor or minimal, patients with poor or minimal donor skin, like all those sun damage patients or skin disease, and maybe in these non-healing lesions. All right, thank you.
Thank you, Dr. Alford, for sharing with us this incredible experience with Maitre Stem.